This is Chris. This is a 64-year-old lady, and that's when all of this transpired. So she went to see the surgeon. She had carotid endarterectomy. I think you can see on the history slide she's hypertensive, hyperlipidemic, diabetic, etc. So she has risk factors. And she came to see me immediately about several months after that, which was approximately 2 months ago. And she was having recurrent symptoms, the same ones she had before her surgery. Her surgeon actually sent her here because he did an ultrasound, which showed, as you can see on our films we took about 2 months ago. If someone can pull those up, you can see a lesion in the common carotid, which looks like where the cross-plant was placed. And then you can also see a lesion up above that in the internal. We draw a line perpendicular to the inferior arch, to the bottom side of that arch. Draw a perpendicular line across the top of that arch. And anything that's above that line is a very favorable arch for us. So 2 months ago, if someone can pull those up, you can see a lesion in the common carotid, which looks like where the cross-plant was placed. And then you can also see a lesion up above that in the internal. We draw a line perpendicular to the inferior arch, to the bottom side of that arch. Draw a perpendicular line across the top of that arch. And anything that's above that line is a very favorable arch for us, such that we can go from the descending aorta with a fairly straight shot. So I think you can see in all of these vessels that we have a fairly straight shot to the right and left internal carotid artery.
So any ideas?
What equipment are you planning to approach that with?
Todd wants to show you this Gore device, and then we're going to go over to Ramey to do a case while we get prepared with it.
So this is an antegrade perfusion case, right?
Right. So this is a proximal protection or flow reversal system, and this is the Gore system. So I think you can see there's a balloon on the end of the sheath here, at the sort of the working end. Back here, we have a port to inflate the balloon. We have a working port to insert the balloon with stents, wire. And then we have another arm here, which is the one that we're going to connect to this filter to perform the flow reversal. So we'll create an AV fistula from the carotid.
So the benefit, Ty, is that the arterial blood flows through that filter back into a vein, right? So the blood isn't lost.
That's correct. So we can either have active or passive aspiration when we do that, or reversal. And we also have a balloon here that we're going to use to occlude the external carotid artery while we're doing this. So there'll be a balloon inflated in the external carotid and a balloon inflated in the common carotid, and that is going to allow us to have a flow reversal. So you see the sheath tracking around into the common carotid. This sheath has a real long dilator on it. So
what sheath is it, Ty?
This is the for the neural protection system.
So I think you can see the introducer and then the sheath coming
So it's a 10 French sheath?
The carotid.
It's 9 French, 9.5.
And we have a 10-French long sheath in the groin.
So Steve got this up into the common, and then he just basically holding the wire and the introducer, telescope the sheath into the common carotid, sort of at the level where we're going to be working.
Okay.
And we wanted to position this where we'd be able to inflate the balloon in the common and actually see that, and then see the area where we'll be working in the common and the internal carotid. So we've done some road mapping. What Steve's doing now is getting ready to...
I've placed the external carotid balloon in the EC port right here.
And so since we have a stenosis in the common carotid, before he actually positions this, I'm going to inflate the common balloon.
But do you think we ought to take a new road map, since it's moved a little since we took that one, before we start? So
I think you should. That's
is that blurry to you, Chris?
Stenosis in the common carotid.
So now
we'll actually
if you
inflate
move
that proximal balloon
patient,
before we
be able
put
to
the
see
balloon in the
balloon on
external
sheath?
carotid.
Yeah, so the balloon's inflated around the cup of the sheath.
And now Ty's going up on the external. And we're protecting all this time.
Oh my goodness.
So here's
So
the
now you're
common
going to
carotid
create
balloon.
this AV shunt through the the femoral vein, right?
It's correct. We have it on active or passive aspiration now, but I think the
No, I see the balloon up. The balloon.
When you say passive, Ty, you just mean that the blood pressure is driving the flow?
Stop. Right.
So the external balloons will be here.
Aspirating with the...
Are you sure the
approximately
balloon's
this
not
distal
inflated
marker.
right now with a bubble on it? See that? Yeah, it's inflated. See that?
Yeah, I see it now.
Can you see the external balloon,
I
Chris?
think so.
Yeah, I think at the bottom there.
And you see it looks like it may have a little air in the balloon.
No, he's talking about the external, I think.
So what Ty's going to do now is he can determine if we have proper protection by injecting here.
So the biggest problem with all of the occlusive devices is missing the lesion. So how do you avoid losing track of the lesion?
I think it needs to be inflated a little bit more.
So Ty's inflating the external just a little more.
So I think you can see the sheep took a little bit of work, but now we have reversal.
Do you want to record that?
Yeah, I see that, Ty.
You saw the injection.
So are you going to pre-dilate, Steve?
Yeah, we're
We're going to
advancing.
pre-dilate, so
with
he's
the
going to
wire.
advance the wire. I want the engine press to do.
Yeah.
So what size balloon?
Can I have a clipping device?
It's on there.
4x2.
So now you can see the coronary balloon going up into the internal carotid. We have a balloon in the external and a balloon in the common carotid with flow reversal. This is just a balloon for predilatation.
So, Chris, it took us a little time to make sure we got this system in the place where we want it. But the thing we've done is all the equipment that we plan to use, we have it open. So it's just a matter of peeling back the layers. We have the predilatation, post-dilatation, and balloon and the stent.
What stent are you
already
using,
open.
Ty?
This is a
10 by 40
10 by 40
wall
wall
stent.
stent.
10 by 40 what?
Wall stent.
So again, chosen because of its deployment properties, because
So how
it's
do you-
closed cell, because it's easiest to use? Why
Do you like
Yes.
that position?
Probably all of the above.
So I think you can see the stent goes into the internal and it's
Yeah.
still, the proximal end is in the common carotid.
You have the post.
Yeah, there you go. You see the live flow here, Chris?
Nice, Steve.
Good.
That's a small artery.
Yeah, we measured it. We chose an 8 by 40, although the common was maybe a little closer to 6.5. And so now do you want to do it?
So you have the clock running for his ischemic time?
Well, she doesn't seem very ischemic. She's squeezing her duck and talking.
I'm talking.
So do you want to
Did-
post-deal this?
Yeah.
Did the patient squeeze the duck, or was that the nurse?
Yes, it was. And she also wanted me to correct, it's her birthday today, and she's 65, not 64, as I told you before. So this is the post-deal balloon.
So, Ty, you're still doing passive aspiration, just the blood pressure's...
I think I'm just getting in Steve's way, but yeah, I'm doing every time we
Every maneuver.
make a maneuver where we cross that area, even though we haven't stented now, I do active aspiration as much as possible. But you know, when the TUI is open, there's the risk of getting air. So it's sort
Where's your
of a
duck?
combination
Megan?
of working with Steve.
Besides balloon.
So it's a 5 by 2, and every time we inflate the balloon, you can see on the image that she coughs. So you want to stop there and take a picture?
I'm going to take these down. So go ahead and deflate now.
And she also felt that when we went up. Okay, so
Deflate these.
So that was the post-dilatation, and what we're talking about is
Blood pressure.
active versus passive
heart
aspiration.
rate,
So if you leave
100.
the system open, then there's the passive shunt that's been created between the artery and the vein,
Yeah,
as
we
opposed to
did the
using a
post-deal.
syringe to actively aspirate.
That was quick.
Yeah,
So take the ECA out.
all right, quick.
Take the ECA out.
Take it down.
Yeah.
Something like that.
Get it on it already.
Give me a 20.
So, Ty, you're actively aspirating now?
I'm active aspirate. Steve's going to pull the ECA balloon out. So this is outside of his stent now. So he's just going to watch this and make sure that it comes out easily.
So we're pulling that behind the struts.
Yeah.
Instaplated,
the
and
balloon
it
being
came
That came
pulled
out pretty easy.
from outside of the
Okay.
stem.
So I think we can take our post result.
Let the other balloon down.
Okay.
So that external balloon was trapped behind the
It's
strut?
trapped behind the stent, so you really just have to make sure. It takes a little time for it to deflate, so just make sure that it's adequately.
Has that ever been a problem for anybody?
Supposedly it's been a problem, but
Trapping the external balloon behind the stent in the common carotid?
yeah, there are a couple of different tricks. One is
so
they recommend
that-
just loading a balloon.
You ready?
Yeah, take the wire.
Take this one out. Okay, you want to bleed these really good?
Yep.
And make sure we have no air. Okay.
Kind of self-expanding stent,
Yeah,
I would think
let it
that
come back.
wouldn't be a problem.
Let it bleed back in there.
Let's do this.
So are you still having flow reversal?
No, we're finished. We got all the wires out. We have flow reversal turned off. We're just bleeding the system, making sure we have no air. This was a carotid endarterectomy in 10 of 08, and she restenosed it immediately thereafter.
So that's another predictor for bad outcome is early failure of the endarterectomy.
Okay, you ready?
10:08, so that's 6 months.
And then we'll take a DSA. It looks like a little bit of spasm there. I'm going to mag up and go lateral.
Do you want to give some nitro, Steve, or?
Sure.
Thank you for this.
Sure. Can you take these wires?
Again, that's an awful lot of stent, and there is no evidence at all that the length of stent or the amount of stent has anything to do with outcomes. So I wouldn't cheat myself on short stents. So how much nitro did you give, Steve?
200.
Okay, you want to move up so we can see a little, so we can see where that spasm was. Is this
Give me a
DSA?
final angiogram here.
Okay,
guys.
take a big deep breath in and hold it. Hold right there. Don't breathe, move, or swallow. Real still. And breathe. Just want to go straight
So there's
up
still a
there.
little bit of narrowing at that distal tip, huh?
Yeah, I agree.
And so why don't you give a little bit of neo?
What do you think about that?
I think so too. We knocked her blood pressure down a little bit with the nitro, but we're going to take a second angle just to make certain that there's no dissection. And
It'll
if,
mag it up some.
mag that up.
So the question then comes, is
And
what does drive you to do
Deep
something
breath
at this
in and
point?
hold it for
And
me.
for me, it has to be a flow-limiting problem.
Hold right there.
Not just a
Don't
cosmetic problem.
move. And so that looks a lot better now.
Yeah.
And so I don't think that's a dissection. It's spasm. It's almost gone. And even if the spasm remained after nitro, I would still not do anything additional. So I think we're going to move. Chris, you don't have any more questions?
Actually, we're out of time.
Okay. I think we'll stop this one right here. I don't know if anyone from the panel, so basically this was a patient that had a endarterectomy, came back with symptomatic carotid disease, and then was treated with flow reversal using the Gore proximal protection system. And I think a couple of things that were important in here were the sort of the choice of the embolic protection that was used. The other, just on a technical standpoint, is making sure that you have all the equipment already open. So everything that was used, the balloons to pre-dilate, post-dilate, and the stent, are already open and on the table or on the film before you start the case. And I think that's important for you to have everything ready so that you can work in an expeditious fashion, because certainly the longer you maintain the flow reversal or the longer you're intravascular, the more likely you are to have complications. Any comments from anyone on the panel?
Taiwan, that's the choice of the protection device. In that case, I would prefer a filter, because you have to cross along the lesion of the common, and you have to cross a stenosis, so you have a risk of emboli. So with a filter, you don't have more risk. So in that case, I think a filter, it's easier, and if you compare the result with reversal flow technique, I don't speak on microemboli. That's the problem. I agree with you for microemboli, cerebral microemboli. this reversal flow is maybe better. But if you look just at the 30-day complication rate, death, stroke, myocardial infarction, you have the same result with filter and with reversal flow. So it's difficult to say a reversal flow is better than a filter. And for that case, I think it's easier because you can cross very easily with a filter and you don't have the problem because a reversal flow, it's a very good technique, but it's more cumbersome, more difficult to use. It's not for beginner. You agree with me? No? And in that case, we have to cross the lesion, so a risk of embolism and detaching a plaque.
Yeah, no, I think those are all very good points. And one of the issues with using any of the proximal protection devices is that we're very familiar with using the filters because we've had filters for a long period of time, and so we feel much more comfortable with them. But the proximal protection devices, either this one or the MoMA device, I think are very user-friendly once you develop some expertise with it. The issue here, and I agree with you, there is a risk of embolizing when you cross that common carotid stenosis, and that was the reason that we chose to use the proximal protection because we were able to inflate the balloon and then advance the wire into the external carotid at the same time, so we could actually have flow reversal with only one balloon up, even if you don't have the external balloon. And we felt that that was going to be a safer way to approach this patient. But I would also agree that if you look at results as far as the hard endpoints that have been required for most of the trials, you'll see that there's really no difference in proximal protection versus distal protection. And where we see the significant differences when we do diffusion-weighted MRI, then there clearly is an advantage over using a proximal protection device compared to the distal embolic protection devices.
Maybe the most important step for a case like that, which is a high-risk case, because a long lesion, diffuse lesion, is to aspirate before retrieving the filter or the protection device. So maybe with your device you could do that, but I think that's the most important step, aspirate inside the stent to aspirate, because we can aspirate a lot of debris. And not a lot of interventionists do that. Yeah. I think it's we have to do that. No. Do you agree?
No, I agree, and we routinely don't aspirate when we use a distal filter. If we see visible, debris in the filter, then we may aspirate before we retrieve it. But for 100% of the cases, that's not part of the routine. But perhaps you're right; it should be part of the routine because there is a stagnant column of blood around that filter, no matter which filter you're using, and so there is the potential of having some quote dead space where embolic debris can sit, even if you have a filter. And even if you try to retrieve it.
Mr. Chairman, we move on to the next case presented by Dr. Collins.
Collins, one more question. Regarding stenosis in the common carotid artery when you do HANA retrograde flow from the external carotid distal embolization and aspiration is more important in such cases.
As far as the
no balloon in external carotid and then retrograde filling of the internal carotid via external carotid when there is already a stenosis in the common carotid.
I think there's always a potential if you're not occluding both, and unless the external is completely occluded, there's always that risk of having some some emboli. And it's interesting that when you have a very high-grade stenosis in the external carotid, you're still able to get the wire into the external to occlude the flow there. But certainly there are a lot of different points during the procedure where you have a potential risk for embolization. And one of the things that we talked about during the this last case that you saw was the active versus the passive aspiration. So any of those points where you're doing something that potentially could increase the risk of emboli, you should do active aspiration. And then for the remainder of the case, we're just doing the passive aspiration. If we have time. I have another case I'd like to show you. This is a case of an 84-year-old female. You can read the history here along with me. Lightheadedness and near syncope for 3 months. The MR showed that she had a left internal carotid, 70% stenosis, bilateral vertebral artery stenosis. The angiogram reveals, type 3 arch, right subclavian tortuosity, left vert, ends in pica.
And near syncope for 3 months. She has risk factors in known peripheral vascular disease, and she has a stent in her kidney artery. She underwent MRI, MRA that showed some left ICA 70% and
This also
bilateral
becomes a very
vertebral
interesting
artery,
case because
stenosis.
vertebral stenting is not
She underwent an
FDA approved
angiogram,
and not covered by CMS in the U.S.
So the left vert ends in pica, and her arch is really a, type 2.5, if not 3, and her subclavian artery is very tortuous. And because we love and respect Chris White so much, we decided to use his favorite access, which was radio. We thought that would give us a better approach to this. And so we put in a 6-French sheath in her right radial. We then just advanced a JR4 guide, which was a little bit difficult. Actually didn't really point towards the ostium that well. And so first I tried and failed, and then of course Ty came and was able to actually hook that vert with the wire, past this whisper wire up, and then we were able to advance our guide up over that. And so this is where we're at. Can you show us? Can you show them the pictures that we've taken here?
So now her symptoms were what, Mark?
So she has pretty profound lightheadedness and near syncope for 3 months, and she was worked up for other etiologies, including Holter's and various sundry other things, and this was sort of what we were left with.
Okay, so Steve, you can see here, we use the reference object to size this. We're measuring just a little bit over 4. But you can also see that the tip of this guiding catheter will not line up or become coaxial with the origin of the vert. But for this short distance, I don't think that's going to be a problem. And so we're not selective in the vertebral, but we can see it well enough. If we go through the images that we've done here, just go through each one of them. You can see that, there's a pretty good bend after the proximal portion here. We did multiple views here, and Amanda would just go through those. I think this one probably shows it the best. Part of it may be artifact.
It seems like such a nice angle if you were to come from the groin. Even so, you thought that arch was too close to a type 3?
Yeah, not only the arch, and even getting the catheter, retrograde up the up into the subclavian was pretty difficult. There's almost an S-shaped turn in the origin of the
So I think you can appreciate the tortuosity here.
It doesn't really project that well on the aortogram that you saw, but there's a lot of tortuosity even after you come out of the aorta into the branch vessels.
Yeah, but now this looks like you have pretty much right angle to negotiate in the ostium of the vertebral. That may be more difficult than it seemed like on your diagnostic images that you had catheters placed in the subclavian. You got fairly nice shots of this, so you could do it once, you could do it again. I don't know how the panel thinks, but go ahead and...
No, you may be right, Steve. We don't know until we actually try this.
So, Ty, this is Chris. I like the idea of going from the wrist. I think it is elegant and avoids bleeding issues and other problems. One option here would be to have used a 4 French Cobra or some other smaller catheter that you maybe could have manipulated easier into that vert, and then use the wire and then exchange the guide over that.
Yeah, actually,
rather than just go with the guide.
Yeah, that's what we were going to do. That was going to be Plan B. We went with the guiding catheter, thinking it wasn't going to be that challenging, but it did turn out to be. But we were able to get the wire in. And I think if that had worked, then we would have
Just
used
to end the wire, and here's the tip of the guiding catheter.
French angiographic catheters to help get the wire in, and then exchange for the guiding catheter.
So how would you have done this, Nick?
So what did you pick here?